Okay, here's the second of a number of slide decks that are focusing on infectious disease therapeutics. Here we'll review the antibacterial agents, and we'll go through them more in depth when we talk about each specific condition. But the focus here should be really getting down the antibacterials. What will require you to do in some part is to merge what you remember from basic microbiology and other infectious disease content about which pathogens are involved or a focus of our approach and care. And then we'll look at the therapeutic end of it. And this block will just review the antibacterial drugs themselves. Okay, at this point in the presentation, everything we've talked about to this point are the beta-lactams. We'll now change gears and talk about non-beta-lactams. But important for you to be able to differentiate the agents we've spoken about already, which are all beta-lactams, apart from the agents we're going to talk about from this point forward, the non-beta-lactams, in that if someone has a hypersensitivity reaction to one beta-lactam, they can have a cross-reactivity with a different beta-lactam. Certainly, the penicillins themselves, the cross-reactivity for one penicillin is very high with another. For cephalosporins, for a patient who has a hypersensitivity reaction to a penicillin, is real, and we generally avoid those if the patient has had a serious type 1 hypersensitivity. But if it's not a type 1 hypersensitivity and we're in a pinch, we sometimes will use, for example, a cephalosporin in a patient with a allergic reaction to penicillin, as long as we're pretty confident it wasn't a type 1 type reaction. And there really are no alternatives but that cephalosporin to use. We'll speak from this point forward about the non-beta-lactams, and for someone who has a pen allergy or a beta-lactam allergy, the agents we speak from this point forward generally are not problematic to use. In fact, we often will choose something from this point in the presentation onward if someone has a beta-lactam allergy.
Let's spend a few minutes talking about vancomycin. Vancomycin is a pretty difficult drug to use and pretty much is only going to be used in acute care settings, sometimes continued in the home care setting or in longer term care settings once we kind of establish the appropriate dose for a patient. But dosing vanco becomes pretty problematic and usually requires a team approach in the hospital. We're not going to really talk about the other two non-beta-lactams that are affecting bacteria so well. These are sort of unique drugs that have a pretty minimal approach. Maybe the exception here might be fosfomycin, which is becoming a more commonly used single-dose entity recommended by infectious disease in certain limited circumstances. But that won't be our focus here. So vancomycin's been around for a long time. It's an intravenously used drug. The only oral formulation of vancomycin we ever use is for Clostridium difficile infections that are local infections in the gut. The reason for that is vancomycin orally is not absorbed to any extent. And so it really, if you've got an infection that's outside of the gut wall, you're never going to get any achievable tissue levels of vancomycin with an oral dose. Maybe advantage of vancomycin is that it doesn't have a beta-lactam ring, so it's not a risk for ESBLs or bacteria that produce beta-lactamases. It's not an issue for hypersensitivity for folks who have a pen allergy. But the reactions, the concerns are for ototoxicity and nephrotoxicity. And also we see this infusion reaction if it's administered quickly over 60 minutes or less. And so we often will need to extend the infusion beyond 60 minutes, particularly if we're giving a dose more than 1,000 milligrams or a gram, which is pretty common. In addition to dosing, we'll talk a bit about plasma levels, getting them when we get them, and using, in this day and age, computer applications to appropriately evaluate and estimate and modify a dose. And we'll talk about those based on recommendations that came out from the Infectious Disease Society of America and the American Society of Health System Pharmacists in March of 2020. Most healthcare settings have a pharmacist who helps you do dosing for vancomycin, and so that's going to be helpful in practice. Classically, we've used a 15 to 25 milligram per kilogram loading dose and then 15 milligram per kilogram dosing every 8 to 72 hours, depending on kidney function. That's changed a bit with the newer guidelines, although a lot of patients still can be maintained on those kind of dosing. We are, though, going to get frequent trough levels. Usually we're going to get them when we're close to steady state for vancomycin. That depends on the patient's renal function to know when that's going to be, but it's often before the third or the fourth dose of vancomycin. And we are going to get regular renal function monitoring, particularly serum creatinines. We get them in the hospital every single day. And if we see a bump up in renal function, because vancomycin is nephrotoxic itself, we need to adjust the dose. So the two issues with vancomycin is A, it's cleared renally, and B, it's nephrotoxic. So you can imagine the perfect storm, which happens all the time in the hospital, is that the patient gets a little nephrotoxicity from the vancomycin, which is a dose-related, serum-related toxicity, and that little bump up in serum creatinine, that decrease in renal function, means they don't eliminate vanco as readily. They accumulate more of it, which leads to a higher risk for renal toxicity. And all of a sudden, the patient's in acute renal injury, which thankfully, usually, but not always, is reversible. And so what we don't want to do is institute a drug with a high risk for kidney failure in patients that could be permanent. And all of us that have been in practice long enough have certainly seen a fair number of cases where folks have remained on lifelong dialysis because of the problems dosing vancomycin. We're going to adjust the dose based on the area under the curve projections. We're going to talk about those in a minute, and we typically will use software in the hospital to help us with that. That's usually done by the pharmacist in the hospital in conjunction with your medical teams. So the updated guidelines for vancomycin were updated in March of 2020 based on the Infectious Disease Society of America in conjunction with the American Society of Health System Pharmacists. So I'll try to make sure these get posted online. There's a lot of detail in these that I don't think you really need to sort of go through specifically. And I've included some of the higher level recommendations they make, and we'll try to put them in context in the next couple of slides. So one of the big recommended changes in these guidelines, and I know this is fairly small print, but we're really transitioning from just looking at peak and trough or trough levels of vancomycin to estimate what the appropriate dose is, to instead look at the ratio of the area under the curve to the minimum inhibitory concentration ratios for vancomycin and how we dose it. And we really try to get to a point of 400 to 600 for that area under the curve. And keep in mind, the area under the curve is just a measure. It's a mathematical calculation or an estimate of how much of that dose over time is above this minimum inhibitory concentration of 1, which is considered to be the break point for most MRSA infections when we're using vancomycin. So the older, in point 3 here, the older trough-only monitoring is no longer consistently recommended. But we'd do that in conjunction perhaps with Bayesian calculation software that helps predict that, and we'll go through an example of that in a little bit. So the preferred method in adults in item 8B is to use a software package that helps us calculate this area under the curve modeling based on population norms initially when we start dosing, and then we can customize those results by back extrapolating levels, timed levels, into the same software package and then predicting how this patient's responding to vancomycin. And I know for most clinicians, this is, if you're not a pharmacist, this is kind of above and beyond what you would want to see and want to do. And so just know that there's a pharmacist to really help facilitate this for you in the hospital. There are additional guidelines here for adults about continuous infusions of vancomycin, which is not standard of practice yet, or pediatric recommendations in this slide and the next slide. And here are some of the pediatric recommendations as well. When, as a clinician, I go to dose, as a pharmacist, I go to dose vancomycin, and I do this almost every day I'm working in the hospital because the vancomycin is still commonly used for MRSA in the hospital, very commonly used. I'm going to use a software package. Here's one software. There's multiple. I'm not necessarily advocating global RPH over any other verified software, but this is an area to do vancomycin area under the curve dosing calculations. This is this Bayesian predictive software, and I encourage you to sort of go play with Global RPH or some other software for vancomycin dosing. But know pretty much in the hospital that the pharmacist is probably going to work with you to do this, whether they're using this specific software or they're using alternate software. Typically, you want to, first of all, find the program that's validated and make sure it's up to date because these programs are changing the assumptions all the time. And then when we use such software, we're basing it initially on population norms. So what is the normal typical volume of distribution for most patients who are on vancomycin? And your choice of that volume of distribution is going to depend on the patient's fluid status, but almost universally we default to the program will default to 0.7 liters per kilogram, but you can adjust that if you knew the patient was more or less hydrated. But in general, we usually just start with almost everybody at 0.7 and then we'll adjust the beta based on the levels we get back. We also want to look at the infusion time so we can prevent this flushing reaction that happens pretty commonly with vancomycin by infusing it over at least 60 to 90 minutes. And any dose that's going to be above 1 gram or 1,000 milligrams of vancomycin, we typically want to do that over probably 90 minutes or longer. So the software allows us to kind of select how long we want to consider infusing it. Other things that are embedded in here is we put in elements for the patient's age, their serum creatinine, their height and weight, whether or not they have an amputation. We usually go with the default calculation, Bayesian calculation method that the software will use, but we could select alternate calculations if we needed to, if our population were different, and that's sort of beyond the scope of what you really need to know in practice, but be aware of that. The other thing that we never do is, particularly if this is a software that is online, which is developed by other people, we never put patient identifiers in. So for example, in this software package, it allows you to put the patient's name and location. As a clinician, I would never do that because that would expose that patient's specific identifiable information beyond the bounds of the health system for clinicians who absolutely need to know that to provide care. So it's a HIPAA violation. So we wouldn't really do that. But the software itself is really helpful to helping us predict what type of dosing is appropriate for vancomycin for a patient. So when we initially look at this, I put in this data and here's what pops out. This set of screens. So on the top half of the screen here are some estimated calculation values based on population data. This is not on this patient. This is based on how most patients who get vancomycin will respond. So we estimated that his adjusted body weight for vancomycin was 76 kilograms as opposed to original 81 kilograms that I entered, and that his ideal body weight is 73 kilograms. It gave me some other information as well. It estimated his renal function, his creatinine clearance at about 52 mils per minute. That's a nice thing to know. It estimates that elimination rate constant, or the slope of decay, is 0.048. You as a clinician won't need to know that, but I as a pharmacist am very interested in knowing that because I may find in the future, based on how levels come, that the slope of his decay line is different, and that KEL is going to help me back extrapolate some data into the software. So don't worry so much about that from your perspective, but know from a pharmacist I'm interested in that number. It also predicts the population-based volume of distribution of 0.7 liters per kilogram times his dosing weight gives me a little over 56 liters. And it gives me clearance data and sort of other variables here as well. So the software recommends 647.2 milligrams every 12.1 hours. And that would give me an area under the curve estimate of about 471, which is in our range of 400 to 600 for a presumed MIC of 1 milligram per liter. And so based on area under the curve dosing and based on peaks and troughs, that's a reasonable dose. What's not reasonable is that we're never going to give 647.2 milligrams of anything. and we're not going to give it every 12.1 hours. So we're going to try to change this to something that's more practical. So I've adjusted this, and I just basically said I'm going to sort of adjust this in 250 milligram increments over an 8, 12, or 24-hour interval. So I put in, for the same software, I changed it to 750 every 12, and lo and behold, I get a peak of 29 and a trough of almost 18. That's a pretty aggressive regimen for a patient. And it also estimated the area under the curve is 551. That's also pretty aggressive. It's still within 400 to 600. And the reason why I want to stay below 600 is I want to reduce the risk for nephrotoxicity. The reason I want to be above 400 or 500 even is if they're really sick, because I want to give them enough antibiotic to treat their infection, but not so much that I throw them into renal failure. So this was a pretty fairly aggressive regimen. What I could do is, if I thought this patient had a significant bloodborne infection or they had pneumonia, then I would think this is a reasonable recommendation to start and see where they end up. If this patient had MRSA-related cellulitis, my goals may not be as aggressive for dosing in that, and I might try to do something different for this patient. I might try 500 every 12 and see what the numbers brought me, or some variant of this. But this is a reasonable alternative for most patients. So I'm going to look at, I might look at some different assumptions if I needed to. The last thing I'm going to look at is whether or not I need an initial loading dose. And for most patients, in fact, we would. If we didn't do a loading dose at 750 every 12, then I'd want to dose the next dose sooner than 12 hours. But in this software, it gives me a recommendation that in addition to 750 every 12, I might want to give a 1500 milligram loading dose. And a 1500 milligram loading dose, the formula calculates or estimates based on population norms, again, not necessarily where this patient's going to land, but it helps predict for me that if I give this patient 1500 milligrams, I'm going to get an initial post-distribution peak of 25. That's very reasonable. And I'm going to, in 5 hours, I'm going to be at about 20, and at 11 hours or 12 hours, I'm going to be at 15. And that's kind of nice, because I want to do, so what I may end up with this patient is a 1500 milligram load and then 750 every 12, starting 12 hours after the 1500 dose. And that pretty much gets me where I want to be for a trough of around 15, depending on what I'm trying to hit. I start the next dose, the 750 every 12, at about that point when I reach 15, because he might have a serious infection, pneumonia, or, if he had cellulitis, then I might consider using a lower loading dose, maybe above this is 1250, and then look at redosing him, with a 500 every 12 hours, something like that, if the software predicted that, every 12 hours thereafter, something like that. So I'm going to sort of adjust this based on what the patient in front of me looks like, how sick they are, and how they are, how much vanco they're going to need. But I'm weighing the risk of toxicity, particularly nephrotoxicity, against the benefit of adequately treating him, because keep in mind that if he's septic, that could kill him. So I'm really want to make sure that I'm aggressive enough in regimens, but not too much. And I'm going to get serum creatinines every day, and I'm going to get levels frequently, and I'm going to then use those levels in conjunction with Bayesian software like this to help configure his regimen, and typically that's going to be done with the pharmacist in the hospital. So as we look at the agents here, we'll see what roles they have. Vancomycin covers MRSA, some gram-positives as well, but truth be told, if you get an isolate that's non-MRSA but it's another gram-positive, likely your sensitivity will come back, and you'll have alternatives to vancomycin to consider. And fosfomycin has some coverage for some gram-positive, gram-negatives. It has a sort of a limited space where fosfomycin fits, and we're not going to focus on that here. All right, a couple of other antibacterials. One here is a lipopeptide, daptomycin. Daptomycin is effective for MRSA. We use it primarily as an alternative to vancomycin for MRSA-related cellulitis, or for right-sided Staph aureus endocarditis as an alternative to vancomycin, but clinically in practice, we don't see it used all that much, depending on what you practice. Some settings use it much more than others. And typically you only have MRSA and some gram-positive coverage with daptomycin.